Should I start?
Yes, ma'am. Yes.
Are we live now?
Yes.
Good evening, everyone, and welcome to this session on prediabetes. There are different eminent speakers today who will be dealing on various aspects of prediabetes. But before that, I want to convey one message to everyone that all of us know that the medical fraternity is now passing through a very bad phase. One of the junior doctors in Kolkata in Arjikar Medical College has been brutally raped and murdered in her own institution, in her own department, while on duty. So on behalf of Endocrine Society of India, all of us strongly condemn this event and we want justice. So before starting our symposium today, I would request everyone to observe 1 minute silence to pay homage to this departed soul. Thank you, everyone. So coming to the topic of prediabetes, which is our subject of discussion today, we all know that with the global escalation of the number of diabetic patients, all of us are health aware about diabetes all over the world. But unfortunately, prediabetes has not gained that much importance as it deserves. Can we imagine that at least 136 million people in India itself is suffering from prediabetes? But probably the prefix pre is making this subject a little lightened, and it is befooling people that it is a milder form of disease, and it is basically neglected by many of the patients, not only the patients, but also the clinicians. But we, as endocrinologists, we are aware of the fact that prediabetes is not only an indicator of future diabetes, but it is a state which, being in the spectrum of the same pathophysiological process, it may lead to so many complications, including macrovascular complications, particularly the cardiovascular diseases, including acute myocardial infarction, and also various microvascular complications. And so it needs to be focused on prediabetes today. And not only that, there is ample scope of intervention in this period, so that not only we can reverse to normoglycemia and halt the progress to diabetes, but also we can prevent complications. So it is an honest effort of Endocrine Society of India today to discuss on various aspects of prediabetes, so that the awareness is increased among the clinicians, and so that it can make clinicians encourage to be in a habit of intervening prediabetes either by non-pharmacological or pharmacological method, whatever it may be. So without wasting much time, we would start our symposium, and I would invite Dr. P.K. Jabbar to initiate today's session by the context setting. Dr. Jabbar doesn't need any introduction in this platform. He is the ESI president, and please focus his CV slide. I think it's available here.
Backend team. I think Dr. Dr. Jabbar sir doesn't need an introduction. We can just.
She doesn't need any introduction.
Okay.
So kindly share your slides, sir. And
no need, no problem. May I start?
Please, Dr. Jabbar.
Yeah, okay. Good evening, everyone. Regards and big thanks for all my friends who are sitting in the crowd. First of all, coordinator Dr. Shaila, the great hero Dr. Sanjay, distinguished speakers. I don't want to name everyone here. All doyens in the field of endocrinology, I would say. I wanted to congratulate Dr. Shaila for setting up this type of activity. In fact, she only initiated this activity. I would say she's a master brain for conducting this pre-diabetes celebration of ESI. And she has chosen beautiful speakers, starting from Sanjay ji up to see whatever junior fellows sitting in the crowd. My dear friends, if you look into the INTAB study published last year, so diabetes prevalence, it's around 11.4%. Pre-diabetes prevalence is 15.3 national average. And if you take the data from Kerala states, it's around 19. Most depressing issue is there is no demarcation between urban and rural population in Kerala state. Most of the states are having some sort of demarcation in terms of prevalence. Rural, of course, low incidence or prevalence, sorry. And urban, yes, high prevalence. Kerala is really upsetting. And if you look into the data, I'm damn sure that so Dr. Sanjay is going to discuss all these prevalence data. The life expectancy, 25 years back, it was 62. Now, 2024, it's becoming 70.62 years. That is because of many reasons. One of the reasons is, of course, healthcare facilities are improving, but diabetes and its brother and sisters are becoming a real nuisance to the medical fraternity. Now, see, pre-diabetes, of course, is early diabetes, which is associated with a significant increase in morbidity in terms of vascular disease. There are a lot of contributing factors. But we know one thing, this pre-diabetes is treatable and reversible. This will be translating into the number of years of healthy years for our human being and our patients also. My dear friends, it is very essential to concentrate or give importance for preventing diabetes, even preventing pre-diabetes also. We healthcare professionals, we have a lot of responsibility to reduce the burden of this disease in collaboration with the governmental and non-governmental organizations. ESI is very, very active. I think for a long years, ESI is very, very vibrant. One of the best person in terms of vibrance and activity factor also. Dr. Sanjay is also here sitting with us, and he is one of the best organizers for arranging this type of awareness programs. I don't want to say a lot of things. This awareness, we should give the importance to the public, health workers, patients, individuals to reduce the burden of this type of metabolic problem. So you'll get a very positive health. That's the only message from my side. And may God bless you. I wish all the best for this, one of the best academic event today of ESI. Thank you very much. I'm signing off for the time being.
thank you, Dr. Jabbar. So I would call upon Dr. Sanjay Karla for his topic, Pre-Diabetes Day, Relevance and Significance, Dr. Sanjay Kalra does not again need any introduction, and you can see his CV here. He is in Bharti Hospital Colonel and past president of ESI, along with past president of SAFIS and IPATH. And I would request Dr. Kalra to enlighten us about the relevance and significance of pre-diabetes care.
Till Kalra sir gets his slides up, does his screen sharing, there's only one thing I want to definitely tell this audience, that the entire concept of Pre-Diabetes Day was the brainchild of Dr. Kalra. This was when he was president and when he was immediate past president, that the entire concept of Pre-Diabetes Day was thought of, and it is the innovation of ESI. I mean, it is which is the entire concept was started by ESI, and then it has spread around the globe. So I think for that was very important for me to really inform everybody about that. Over to you, sir.
Thank you, Dr. Shaila, for those kind words. And thank you, Dr. Sarmishta, for so ably being able to manage the ESI Pre-Diabetes Day webinar. Thanks, of course, to our president, Dr. Jabbar. And also, I would like to mention all our speakers who are spending so much time and effort to spread the word, the good word about endocrinology. We acknowledge this is speaking, of course, to our senior leadership, but also to our juniors, Dr. Abhiday, Dr. Ashish, and Dr. Hari Kumar is with us, Dr. Devaditya is with us. We acknowledge all the time and energy that you put into all this. World Pre-Diabetes Day. Now, this is something we need to speak about, but let me begin with this picture. This is Thor, the Norse god of thunder. Now, what does he have to do with us? First of all, there is a lot of thunder and lightning about diabetes. That is true. Dr. Sharmishta said that we are aware of diabetes. There is also a lot of thunder and lightning regarding pre-diabetes as well. Some things, hit from front and others hit very quietly. And pre-diabetes is one of them. It comes in without thunder. There is another important reason why we bring Thor into the picture, because Thor is the inspiration for the radioactive element thorium. And thorium has the atomic number 90. Now, 90 is an important number. But why thorium now? Thorium is a very long-lived element. It is radioactive, but its half-life is comparable to the age of the universe. So thorium is as long-lived as the universe. When we see diabetes and pre-diabetes, they are also as long-lived as the universe. If you read Charak Samhita very carefully, they have beautiful descriptions of diabetes, and they have very beautiful descriptions of pre-diabetes. If you read it carefully, you will find that they've been able to very easily and very, very descriptively, they've been able to differentiate type 2 diabetes from type 1 and type 2 diabetes from pre-diabetes. So pre-diabetes is as old as the universe, just like thorium number 90 is as long as the universe. The radioactive decay, thorium is decaying slowly. The half-life is in billions, but this is the largest single contributor to internal heat of the Earth. And similarly, if you were to try and pinpoint one particular disease which causes the maximum morbidity on Earth, we might finally end up saying pre-diabetes and obesity. If we were to catch them early, we would prevent a lot of morbidity, mortality. And thorium, the story goes on, thorium is 3 times as abundant as uranium in the Earth's crust. In the galaxy, it's one of the rarer metals, but in the Earth's crust, it's very abundant. Similarly, pre-diabetes is abundant. And like Dr. Jabbar said, there are many states now, like Kerala, where pre-diabetes and diabetes are at equal prevalence. Pre-diabetes in rural areas and in and urban areas is equally prevalent. This means that diabetes has become endemic. Pre-diabetes has become endemic to many parts of our country. The same way that thorium is endemic to the Earth's crust. But then 90 is not just about God Thor and about thorium. It is also about the window of opportunity, the window of optimism, and an optimalistic window. 90 is the number of days that HbA1c tells you about glucose control. And if you want to make a meaningful difference in HbA1c, ideally you should do them 90 days apart. Why do we use the word opportunity? So when DeFronzo talked about the ominous octet, he was right. Things were ominous, things were gloomy, things were unhappy. But now we have so many things available, non-pharmacological therapy, pharmacological therapy, you name it and we have it. So it should not be called the ominous octet anymore. Now it is an octet of opportunity, an octagon of optimism, an overview of optimalism, optimistic overview that we have about managing diabetes, about preventing diabetes. And if you want to prevent diabetes, then we need to act early. And because World Diabetes Day is celebrated on the 14th of November, we thought that let's take a day 90 days prior to that. 14th August is important not only from the diabetes window, from this HbA1c window, but also from a political window. 15th of August, we celebrate our Independence Day, and we celebrate with pride. Why should we not also celebrate independence from ill health, independence from disease, from disability, from complications of disease? And that is why also we have taken 14th August. So in 2021, Pre-Diabetes Day Charter was released. And here you see it is signed by the president, the past president, and the president-elect of Endocrine Society of India, along with colleagues from the Association of Physicians of India. And what we said was that we recognize this day as Pre-Diabetes Day and take a pledge that we will work together as individuals and organizations towards managing pre-diabetes. This was followed by an expert group consensus on pre-diabetes in India. And with pride, I would state that Dr. Sheila Sheikh was one of the authors of this. More and more publications came out, and the South Asian Federation of Endocrine Societies also released a statement last year. This was published in a very prestigious journal. The statement was on access to pre-diabetes care, but SAFIs also pointed out a very simple 7S framework for indications for pharmacotherapy of pre-diabetes. Our speakers will talk about this in greater detail. SAFIs also pointed out that it's not just about managing pre-diabetes, it's about preventing it. So primordial, primary prevention of pre-diabetes, secondary, tertiary prevention of pre-diabetes, and also not to forget the newer levels, quaternary and quinary prevention. These were also mentioned by SAFIs. This was in 2021 onwards, and in 2022, we found that many other organizations, all friendly, brotherly, sisterly organizations, decided to own it, the concept of World Pre-Diabetes Day. And we were happy because pre-diabetes management is for all. So our colleagues from IDF Southeast Asia created a very beautiful logo. In blue, they added yellow and green to differentiate pre-diabetes from diabetes and also to link them together. This is the significance of World Pre-Diabetes Day. This is the history. We began 3 years ago, the history of 90. Now, Thor is considered a very strong god in Norse mythology. That strength, let us bring together. And once again, I thank the Endocrine Society of India and the current leadership for their efforts on communication, education, and empowerment. Thank you once again. Thanks to Dr. Jabbar and the entire team, and I look forward to a fruitful discussion.
Thank you, Dr. Kalra, for your excellent and meaningful message on the Pre-Independence Day on pre-diabetes, and probably, hopefully, we will be free of, independent of ill health as far as possible in near future. And now I would call if anyone has any question, you can put it in the chat box. But as the time is short, I would like to call upon Dr. Ashish Sehgal, who will be speaking about pre-diabetes, a window of opportunity, a very useful topic.
Thank you, ma'am. Thank you, Dr. Sarmishta. Thank you, ESI. Thank you, Kalra sir and Jabbar sir. Thank you, Dr. Sheila Sheikh, ma'am. Thank you, everyone, for this evening, and thank you for organizing me. I hope my slides are visible.
Yes.
Okay, shall I start, ma'am?
Yes.
Okay. So as the context has been beautifully laid down by respected Dr. Jabbar sir and Dr. Kalra sir, What we are discussing today is pre-diabetes, or the precursor to the monster of type 2 diabetes. And why do we call it a window of opportunity? That is what I'm going to discuss in the next 10 minutes or so. I'll be discussing about what are the levels of prevention that we have learned, all of us have learned in our grad school in PSM. What is the natural history of progression of type 2 diabetes? How do we diagnose pre-diabetes? What is the prevalence in India? So we know the extent of the problem, and hence why is it a window of opportunity for all of us. Now, as I think Jabbar sir clearly mentioned, the life expectancy of our country has been rising. I mean, at independence, it was somewhere around 35 years. That was primarily because of infant mortality, childhood mortality, communicable diseases. But as our country progressed, I think after 1970, the communicable disease actually took a backseat. And from there on, it has been the journey of non-communicable diseases, diabetes and its brothers and sisters, hypertension, obesity, dyslipidemia, and so on and so forth. We now actually have a life expectancy average of somewhere around 70 years in 2020. So that's double of what was at independence. But as we celebrate our Independence Day tomorrow, so let's, I think, endeavor to improve it further by taking control of the most common cause of mortality today in our part of the world, which is non-communicable diseases, and the vast majority of which actually is by diabetes, hypertension, and dyslipidemia. So this is where we actually currently lie. And what are the levels of prevention that actually we have, all of us have read in our PSM in grad school? Primordial prevention actually is when we prevent the development of risk factors themselves. So here, if we talk in the context of type 2 diabetes, that would amount to preventing the development of insulin resistance itself. That may not be always possible because quite a bit of it is actually genetic in origin. Then primary prevention is where we prevent the onset of disease. And that is where the context of preventing the progression from pre-diabetes to diabetes lies. We cannot have a better example of the dictum in medicine that we so often remind ourselves of. The dictum is prevention is better than cure. We cannot find a better example of this dictum in medicine, I mean, other than diabetes itself, type 2 diabetes itself. So preventing the onset of dysglycemia, preventing the onset of type 2 diabetes is what is the window of opportunity that presents to us in the form of pre-diabetes. Timely recognition and implementation of preventative measures is what is primary prevention in this context, and that is why we call pre-diabetes a window of opportunity. Now, I'll briefly discuss what is the natural history of type 2 diabetes. We all know that at the heart of type 2 diabetes lies a progressive decline in beta cell function. That is the hallmark of pathophysiology of type 2 diabetes. Insulin resistance is there always, sometimes right from birth. It is always there, and it is compounded by poor lifestyle and so on and so forth. Insulin secretion initially tries to keep up with the insulin resistance, but as beta cells fail, there comes a time when insulin secretion is not able to keep up to the insulin requirement because of the resistance, and then first it is the postprandial glucose that rises, and then after that fasting hyperglycemia also ensues. So macrovascular complications, if we see, actually antedate sometimes the onset of dysglycemia, the onset of type 2 diabetes. That is because the common soil for the development of diabetes itself and macrovascular complications is insulin resistance. Microvascular complications usually sometimes occur at the diagnosis, even sometimes before the diagnosis of type 2 diabetes, because diagnosis can sometimes be delayed. And sometimes we see even in pre-diabetes that microvascular complications do occur. So onset of dysglycemia, before that is what is the time we call pre-diabetes. Pre-diabetes is not naive. It can be associated with macrovascular complications, ASCVD risk, and sometimes even microvascular complications that we so often see in our clinical practice. So this is what the background of natural history of type 2 diabetes is. Now, how do we diagnose diabetes and pre-diabetes? Now, if we go by the ADA criteria, impaired fasting glucose is what is defined by a fasting plasma glucose of 100 to 125 milligram per deciliter. 2 hour 75 gram post OGTT glucose if it is more 140 to 199, that is impaired glucose tolerance, and HbA1c of 5.7 to 6.4. So this is what the definition of prediabetes is. WHO actually does not endorse HbA1c as a diagnostic criteria for prediabetes. And another difference actually there is that impaired fasting glucose, WHO defines it as 110 to 125 milligram per deciliter, compared to ADA criteria for impaired fasting glucose, which is defined as 100 to 125 milligram per deciliter. So this is a slight difference, but it has huge implications, because if we apply the ADA criteria, the prevalence of prediabetes and diabetes combined in India goes up to 44%. Yes, you heard it right. It's 44%, roughly close to half of our population, if ADA criteria is applied, is actually dysglycemic, by which I mean it is either diabetes or prediabetes. Now, prediabetes actually, yes, we have diagnostic cutoffs. Yes, 5.7 onwards, it is prediabetes. But these cutoffs actually we use so as to have a definition, so as to define the prevalence, so as to formulate guidelines. But as a matter of fact, the association between glycemia and complications is actually continuous. It is not that right after 5.7 they start coming, and before 5.7 it does not occur. No, the association is continuous. We know it from large studies, landmark studies like UKPDS and DCCT. The continuous association, and 7.5 is used, 6.5 is used as the diagnostic cutoff for type 2 diabetes, because at that point of time, retinopathy risk goes up dramatically. But before this cutoff as well, even before the cutoff of 5.7 of prediabetes, the risk is continuous. That is what the important thing is here. Now, Jabbar sir spoke of the INDIAP study, the ICMR-sponsored INDIAP study, which was a landmark study, I would say, and across the length and breadth of our country, a survey trying to define what the problem is, trying to ascertain the prevalence of diabetes type 2 as well as prediabetes. Now, what we can see here is roughly 15.4% of the urban Indian population and equally 15.2% of the rural population is actually pre-diabetic. So 15.3% is what pre-diabetes prevalence is. And diabetes is somewhere around 11.4%. But as I mentioned, WHO criteria was used for defining pre-diabetes here, which is 110 to 125 milligram per deciliter was the cutoff that was used for defining impaired fasting glucose. If, however, apply the ADA criteria, the pre-diabetes prevalence comes out to be 32.8%. The total dysglycemia prevalence is 44.2%. Huge prevalence given the population of this country. If this is what the prevalence is, I mean, we can estimate the kind of numbers that we are looking at. So we see pre-diabetes, 136 million people actually, based upon WHO criteria, are pre-diabetic. Combine it to the prevalence of abdominal obesity, I think we are sitting on a ticking time bomb, ready to explode, and I mean go towards full-fledged type 2 diabetes, and with its baggage of micro and macrovascular complications that all of us know. So this is what the problem is. Now, once again, if we look at the prevalence in the map of our country of diabetes and pre-diabetes, we see diabetes actually has high prevalence in the southern states, the relatively highly prosperous states of our country. In these states, pre-diabetes prevalence is relatively lower. So what we can see, it's probably, diabetes prevalence is plateauing off here. But the problem here is in the central, more populous states of our country, particularly UP, MP, and Rajasthan, prevalence of diabetes is not that much, but the prevalence of pre-diabetes is more than 15%. So this is where the problem lies. I mean, these individuals who are pre-diabetic in these parts of our country are going to transition into type 2 diabetes if not taken care of. And that is why we call this a window opportunity. Now, there are many problems with diabetes in Indians. We keep on talking about this. We are more viscerally obese. We develop diabetes at a younger age. Another important point that needs to be highlighted here is that the annual risk of progression to type 2 diabetes from pre-diabetes in India actually is highest across the globe, which is 18%. So which means that the prevalence data of pre-diabetes is all the more important, because 18% of these individuals annually are going to transition into type 2 diabetes if preventive measures are not put in place. So that is what the problem is, that is what the opportunity is. And if not taken care of, this is what is going to happen at the individual level, at the society level, and at the national level. We are not ready. I mean, no country can be ready to deal with such a big prevalence of a disease, which comes with its baggage of atherosclerotic cardiovascular disease. 40% of these will develop diabetic kidney disease. I mean, there are huge healthcare implications, huge financial implications, and hence we need to put down and start working on it. So to summarize my presentation, as we know from the INDIAP study, pre-diabetes is hugely prevalent, so much so that if the the ADA criteria is applied, the prevalence goes to more than 30%. Yes, it is a precursor of type 2 diabetes, and hence this is the stage of primary prevention of diabetes. Unchecked, as I mentioned, 18% of these individuals will transition to type 2 diabetes annually. It is not naive. Pre-diabetes is not naive. It has associated macrovascular risk because of the common soil of insulin resistance, which leads to both diabetes and ASCVD. Pre-diabetes also comes with microvascular complications as well. And it indeed is a wide window of opportunity, because as my fellow colleagues will discuss in further presentations, that if some measures are put in place, individual level, society level, if measures are put in place, we can prevent the progression to type 2 diabetes and hence prevent the, ticking time bomb from exploding. We need to tame the monster while it is still asleep. If it gets up, if it wakes up, it will be a huge problem for us. So I think that's all from my side. Thank you. Thank you so much.
Thank you, Dr. Ashish Sehgal, for your excellent deliberation on the pre-diabetes, a window of opportunity. So definitely it's a correct attitude that prevention is always better than cure, and we all know that diabetes is not a curable disease, but pre-diabetes is. So I think before the next speaker, Dr. Debaditya Das comes, one thing I want to ask you, that you have emphasized that macrovascular and microvascular complications, they are the main concern in pre-diabetes. So can you give some data, how many patients have cardiovascular morbidity and how many have retinopathy, neuropathy, or albuminuria and CKD in pre-diabetic state? If you have, you can highlight those things.
Ma'am, even at diagnosis of diabetes, we know from the UKPDS that a good 40% individuals actually have some form of microvascular complications.
Yes.
So, ma'am, exact pre-diabetes data I am not aware of right now, but even at diagnosis of type 2 diabetes, many individuals do already present with, these complications. And we see patients actually who come to us and tell us that they develop diabetes many years after they develop atherosclerotic cardiovascular disease. So, CVD actually has its origin from insulin resistance itself, not pre-diabetes actually. Pre-diabetes not just leads to ASCVD. ASCVD comes actually from insulin resistance rather. Insulin resistance is a common soil that leads to both pre-diabetes, diabetes, and ASCVD, and also, of course, PCOS in women as well.
So far, I can remember from different studies and all those things that at least 8 to 12%, we are more concerned about macrovascular diseases, but at least 8 to 12% has retinopathy in pre-diabetes state, and also neuropathy up to 25%. So these are also important, and 15% has microalbuminuria, and DKD can develop in different studies from 4% to 26%. So CV mortality and morbidity is definitely very important, but other microvascular diseases are also important. And another thing I want to highlight, that 8.4 to 12.3% are pre-diabetic among adolescents also. This is very alarming in our country. Very nicely taking the topic, Dr. Sehgal. Now I would invite Dr. Debaditya Das, who will be talking on pre-diabetes. What do the trials say? So evidence-based medicine again, Dr. Debaditya Das. You can see the CV of Dr. Debaditya Das. He is a very young, promising endocrinologist working as senior resident in the Department of Endocrinology of IPJME at Kolkata. So Dr. Das, please start your deliberation.
Thank you, ma'am. First of all, I would like to thank Sarmishka ma'am, Shaila ma'am, Kalra sir and Jabbar sir and the whole ESI administrative team for giving me the opportunity. And I would also like to congratulate uh, Dr. Ashish Sehgal in very well deliberated talk. Now I would just try to further this occasion, further deliberate on this occasion regarding the what all evidences do we have. So my topic is pre-diabetes. What do the trials say? I hope the slides are visible. In this, I not only will talk about only the randomized control trial, but also will touch upon some of the epidemiological evidences that are available for pre-diabetes in this study. So, as we discussed, it is pre-diabetes is intermediate state, or even can be called non-diabetic hyperglycemia. It is a high risk state for developing diabetes with a 70% lifetime risk and certain cardiovascular and other complications. So the National Diabetes Statistics Report from the US CDC 2020 reported that 88 million people aged over 18 years, that is 34.5% of the population, was in this stage. And we already saw how much it is prevalent in our country also. Estimated prevalence was 14%. However, recent data suggests that it is even higher. I won't go into the definition already discussed by Dr. Sehgal. So, regarding the pathophysiology, it is a development from diabetes from non-NGT, and it is a continuous process. The insulin sensitivity reduces 13 years before the onset of type 2 diabetes, and a steeper decline is seen 5 years before the diagnosis. So, we already discussed that progression to diabetes can be seen in almost 70% of individuals with prediabetes, and it can go as high up to more than 90% of individuals in as seen in Chinese diabetes prevention trial. So this is the graph which displays how the values of the fasting glucose and 2-hour post-load glucose increases, and accordingly we can see that the markers or the indices of insulin sensitivity and the beta cell function decreases. So there have been certain epidemiological study also. We touched upon this topic that not only diabetes but pre-diabetes also can have impact on the microvascular and macrovascular complications, and the strongest supportive evidence for any microvascular complication is the association with the autonomic neuropathy, decreased heart rate variability, decreased postural changes in heart rate, and increased prevalence of erectile dysfunction has been seen in men. However, there were no consistent evidence of late markers of diabetic neuropathy like orthostatic hypotension or decreased expiratory-inspiratory ratio, and these were found in the study that was conducted by Wu Js et al. In China. Again, sensorimotor neuropathy also can be there. Small demyelinator fibers are damaged in IGT, and there are evidences as per the CORA study group. They have found that there is decrease in distal intraepidermal nerve fiber density and also quantitative loss of certain pseudomotor responses. In the enhanced data, it has been demonstrated that there is also association of prediabetes with micro and macroalbuminuria with increased glycemia, while the incidence of micro and macroalbuminuria were certainly less in normal glycemic individuals. People with not only with diagnosed diabetes but with impaired fasting glucose also had higher rates of kidney damage. There is certainly early changes of retinopathy in individuals with prediabetes, and there are changes of certain measures of retinal vascular changes, such as if it is examined, there will be low arteriole to venule ratio, increased renal arteriole or venular caliber can be seen. And this has been taken from the OSDIAB study from diabetes. And not only the microvascular complications, but in prediabetes, people may also experience coronary atherosclerosis, macrovascular complications. And this data has been shown along with pathological, histopathological data also with number and grade of yellow plaques, and has been published by the ADA in 2013. So most of the trials actually revolve around how we can actually prevent prediabetes transitioning to diabetes, cause reversal of the prediabetes. So after the complications, I would like to focus your attention on the studies that have been done, certain interventions that have been made so that the prediabetes doesn't progress to the diabetic state. And these studies target two most important modifiable risk factors, that is obesity and physical activity. Finnish DPS study, that is a Finnish diabetes prevention study, and the US diabetes prevention program was done regarding this, and it had a 3-year follow-up, which reported that there is almost 58% risk reduction. And in the DPP study, the US DPP study, most important determinant of risk reduction was weight loss. Every 1 kg decrease reduced risk by 16%. The DPP diabetes prevention program, US DPP study, also examined the effect of metformin, and metformin tablet given 850 mg twice daily reduced incident triglyceridemia by 31% over almost a 3 years follow-up period. However, in this study, it was seen that the physical activity was having a more profound effect on diabetes, pre-diabetes to diabetes transition compared to metformin. However, in India also, we had our own DPP study, diabetes prevention program 1 and 2, which showed that metformin, rosiglitazone, these drugs had almost similar effect compared to your lifestyle changes. So this graph actually shows you the cumulative incidences year after year when compared with placebo. Metformin and lifestyle were actually efficacious in reducing the transmission of the pre-diabetic to diabetes stage. However, in the US DPP program, the lifestyle changes were of more importance than metformin. We talked about the Finnish diabetes prevention study. Here, there were certain intervention groups. So one intervention goal was given as weight reduction beyond 5%. One intervention was to limit fat intake less than 3% of the total energy intake of the day. Then saturated fat intake of less than 10% of energy intake, fiber intake of more than 15 grams per 1000 kilocalorie, or exercise of more than 4 hours per week. And all of them, when compared with the control group, showed that they were efficacious in reducing the incidence of diabetes. This is a list of trials that have been done regarding the physical activity and dietary interventions, and how they can actually improve your chances of not developing diabetes, starting from the Ducking Chinese study, from the Finnish DPS to DPP. There was a Japanese trial also which showed a similar thing. And also we had our own Indian DPP study. One was with metformin, and another one was with diet, exercise, and pioglitazone. Then coming to the drugs specifically, we already discussed the role of metformin. It can, there is evidence that it can lower the risk up to 45% in patients having IGT. As we discussed, there is mixed evidence. The effect was similar to lifestyle intervention in the Indian study. However, it was less effective than lifestyle in the US trial. Thiazolide indulgence, we already know, as per Dr. DiFronzo, these are the only drug that actually hits the actual pathomechanism of diabetes. And these were tried to see whether it can stop pre-diabetic individuals from developing diabetes. In the DREAM trial, it was shown that rosiglitazone was effective and it reduced 60% the incidence of diabetes risk. However, there was a slightly increased risk of heart failure. And as we all know, rosiglitazone is not used anymore. However, we still use pioglitazone or Actos, with which the ACT NOW study was done. And it also showed that the risk of diabetes decreased by more than 70%. It improves diastolic blood pressure and also HDL level, and it reduced the carotid intima median thickening. So in thiazolide indulgence also, we saw that in the Indian DPP2 study, which involved pioglitazone along with lifestyle intervention, showed similar effect. Now, what about the other drugs? A trial was done called Stop NIDDM in 2002, and the results were published in Lancet. And it showed that even acarbose had decreased the cardiovascular disease and hypertension risk. There was 25% relative risk reduction for diabetes. However, it was accompanied with certain side effects, which you all know can accompany alpha-glucosidase inhibitors. There was also a trial with voglibose, an unnamed trial, so to say, and it also showed a 40% reduction in developing diabetes. Now, we will have a detailed discussion later, but there is data with certain newer drugs, the GLP-1 analogs, of reducing the chances of developing diabetes. Exenatide and liraglutide, both evidences are there for both, and during a 1 to 2 year follow-up, it produced certain weight loss in obese patients. it increased reversion from pre-diabetes to normal glycemia. However, there were again side effects, expected side effects of nausea and vomiting with the GLP-1 analog. Then there are trials with orlistat, which is known as Zenical, and this trial, Zendos trial, showed that even orlistat can reduce, there was a 37% risk reduction of relative risk of diabetes in obese people, and the preventive effect in this trial was mainly confined to the participants who had impaired glucose tolerance. There is some data from a study by Wang Q et al. And it also showed that fibrates can reduce the lipotoxicity and can have some effect in people with prediabetes regarding regression to normal glycemia. So in our gist, these are the trials actually starting from tripod with troglitazone, a drug which we do not use, till ESI with acarbose. These are the trials that sought to see that whether the pharmacological agents can help us in achieving remission from prediabetes, and most of them were successfully showing that drugs can help us. However, there was a navigated trial with natiglinide, which is a glinide secretagogue, insulin secretagogue, which actually showed that using secretagogue may actually cause problems and reduce the chances of remission from prediabetes to normal glycemia. Lastly, I would like to discuss some data regarding bariatric surgery. The De La Cruz Munoz et al. Performed a retrospective study in almost 1,602 adults of Roux-en-Y gastric bypass and biliopancreatic diversions, and there also people with prediabetes had a more significant weight loss, and all the three groups of type 2 diabetes, prediabetes, and also normal glycemic showed that after surgery, the fasting blood glucose, plasma glucose, had normalized. So these were the data or the evidences that we have with us till date. And this actually shows us that prediabetes has to be viewed as a continuum of a disease, and at-risk population has to be screened regularly, as there are important clinical implications, and this condition should be taken as seriously as the disease it progresses to. We all know prevention is always better than cure, and there is also another important message that even without any help of any drug, it can be managed with lifestyle changes alone only. Thank you.
Thank you, Dr. Devaditya Das, for your wide coverage of evidences for the complications of prediabetes, as well as various interventions which we can use in management of prediabetes, predominantly lifestyle modification, but there are also multiple choices of drugs which has evidences even when lifestyle modification fails. And due to these multiple choices, we can choose the drug as per as patient profile. Thanks again, and I would like to invite our next speaker, Dr. Abhyuday Verma, and he will be talking on lifestyle measures, a very important issue. And lifestyle measures, does phenotype and precision matter? So this is the topic which will be covered by Dr. Abhyuday Verma. He is a very eminent endocrinologist from Indore, and there are several publications and many work done by him, which has been focused here. So, Dr. Verma, will you please start?
Good evening, everybody. Thank you, madam, for the kind words. And at the outset, I'd like to thank the whole ESI team, Dr. Jabbar sir, Dr. Kalra sir, Dr. Sarmishta madam, and Dr. Sehla Sheikh for giving me this opportunity. And thank you, Dr. Devaditya, for nicely highlighting some of the lifestyle intervention trials, which has made my talk easy. And as Madam has already highlighted that lifestyle measures play a very important role, especially when we talk about the halting of pre-diabetes or its progression to over-diabetes. And in this lifestyle intervention, now we talk about the phenotypes and the precision medicines, whether they have a role or not in the prevention of diabetes. So as we all know, this has been discussed. I won't go in detail, but pre-diabetes is basically an intermediate glycemic state, which not only depends on the hyperglycemia level, but according to the age, sex, body mass index, genetic, environmental, and ethnic characteristics. So this basically makes this quite heterogeneous group of patient, which needs individualization according to the phenotypes and various other parameters. So to improve the efficacy of lifestyle interventional programs, a precise understanding of pathophysiology and different phenotypes of pre-diabetic population is required. And this picture we all know very well, whether it's a type 1 diabetes or type 2 diabetes, various factors, the genetic background, the environmental factors, they have an interaction at various levels, leading to the heterogeneity of diabetes and pre-diabetes also. So this makes, again, lifestyle interventions very heterogeneous and to be individualized. We have already heard that there are various definitions of pre-diabetes given by ADA, WHO, and IEC. Basically, they talk about the impaired fasting glucose, the impaired glucose tolerance, the impaired A1C level, along with insulin resistance and beta cell dysfunction. Again, these makes different phenotypes. And talking about the precision medicine in the management of pre-diabetes, we have the precision diagnosis, precision therapeutics, precision prevention, precision treatment, precision prognostics, and precision monitoring also. So these are basic definitions where I would just talk about the precision prevention, which uses a person's unique biology, environment, and or context to determine their likely response to any health intervention and risk factors, and to monitor its progression towards the disease. And in this, we have precision monitoring also playing a very important role, which can be done with digital apps, various sensors, and then the intelligent processing, integration, and interpretation of data through this precision monitoring, which are key determinants of success of the prevention of diabetes or the halt of pre-diabetes to diabetes. And we all know phenotypes, they have genetic factors, environmental influences, and lifestyle habits. So that's why the importance of tailoring lifestyle measures to individual phenotype is very important. And there are benefits seen of these personalized approaches for various health outcomes. And here you can see that the compensatory hypersecretion of insulin is influenced by the genetic variation and the different responses to lifestyle intervention. This we have already seen that how the lifestyle intervention reduces the incidence of diabetes. DPP study also, lifestyle intervention was more effective than metformin. Another very important study which showed again the heterogeneity of various lifestyle intervention, published in Diabetologia 2016, where diet showed mixed results. But with exercise, you can see here the change in aerobic capacity plotted against the change in insulin sensitivity during the lifestyle intervention had non-responders and responders. So again, this makes it important to individualize therapy according to the phenotypes. And this can be due to the phenotype of the brain insulin resistance. We know that brain has got insulin sensitive regions like hypothalamus and prefrontal area. The phenotypes can be according to the body fat composition, like metabolically healthy, obesity, metabolically unhealthy obesity, then distinct liver phenotypes like metabolically benign or malignant fatty liver, the fatty pancreas, which is also known as non-alcoholic fatty pancreas. So all these phenotypes, they affect the islet cell functions, we know, and its survival, and therefore the capacity for compensatory in hypersecretion, which ultimately leads to individualizing the therapy. So if we talk about this from the starting of gestation, the effects of gestational diabetes on fetal brain, does primary brain insulin resistance exist? And this is the concept of pathogenesis of type 2 diabetes mellitus, as I have already in previous slides. Initially, the brain insulin resistance, which leads to obesity, the metabolically healthy and unhealthy type, leading to fatty liver and fatty pancreas, and ultimately leading to failure of compensatory hypersecretion. So all these factors, different phenotypes may be acting differently and may require different interventions. And this is another one very good table which shows the proposed risk stratification and treatment strategies for prediabetes according to the risk factors, the low risk, medium risk, and high risk, according to HbA1c level, the lifestyle modifications, physical activity, weight loss, metformin therapy, and gastric bypass surgeries if required. So phenotype has a very important role in determining the individual characteristics, the impact of phenotypes on response to lifestyle intervention. This is latest study which shown in these pre-diabetic patients, various tests like OGTT, clinical chemistry, anthropometry, blood pressure was done, and personalized treatment was done for 13 weeks. And then later on, standard primary care was given for 1 year and 2 years. And here you can see in this a quite busy graph, but here basically this is a flow diagram showing the shift in subtypes for participants from baseline to 13. So basically they had 7 subtypes of patients in prediabetes who received a low-calorie diet along with rigorous physical activity. And these subtypes were basically categorized according to the insulin resistance and the beta cell functions. And these were the HIR with moderate beta cell function and liver insulin resistance, MIR with moderate beta cell and muscle insulin resistance, combined muscle and hepatic insulin resistance, the total beta cell loss with insulin resistance and without insulin resistance. So this is basically to show that how many different heterogeneous phenotypes are there which may require different interventions. And this is the same thing, the changes in oral glucose tolerance test response from baseline to 13 weeks in different subtypes of diabetes. And here, so again, almost same thing. And here, this is a very important study, the PLIS study, where different effects of lifestyle intervention in high and low risk prediabetes patients were seen. The pre-diabetic lifestyle intervention study, dividing the patients into high risk and low risk categories. Intervention was done for 12 months and a 2-year follow-up. So they showed that it is possible in high-risk individuals with prediabetes to improve the glycemic and cardiometabolic outcomes by intensification of lifestyle. So, individualized risk phenotype based on lifestyle intervention may be beneficial for the prevention of diabetes. And this is another important study, the effect of 3-year lifestyle intervention on body weight and cardiometabolic phenotype, a post-hoc analysis of previous study, which showed that individuals with impaired fasting with impaired glucose tolerance had similar improvements in cardiometabolic health. Again, same, a high-risk phenotypes with reduced improvement in glycemia was seen with lifestyle intervention. systemic review and meta-analysis showed strong evidence for lifestyle modification compared to various drugs which were mentioned earlier, the GLP-1 RAs, alpha glucosidase, and insulin sensitizers. And this is again same thing. So there are various factors influencing the response to lifestyle interventions, like the behavioral compensation, which differs from patient to patient, the regression to mean, where one or more outcome assessments are done in various different trials, adherence to the lifestyle intervention, and again, the background heterogeneity in behaviors of various patients. Then coming to the precision in healthcare and its role in optimizing lifestyle interventions. So these are basically three areas in precision medicine which could potentially be of value to lifestyle medication. First is, with this precision medicine, we establish a causal benefit for the known effectiveness of any lifestyle recommendation. And second, the earlier identification of risk with a motivating effect for adopting the lifestyle changes at an earlier stage. And last, individualizing the lifestyle recommendation to deal with differences in response. This precision medicine was coined in 2011, and it is used to refer tailoring of medical care to a group of patients with unique molecular or cellular traits, along with environmental and lifestyle factors. So here, the genetic, morphological, and metabolic makeup of patient is considered. This precision medicine in diabetes initiative was taken in 2018 by ADA and EST. It refers to personalized treatment that utilizes the latest diagnostic and therapeutic technologies, along with patients' unique genetic makeup, molecular markers, phenotypic characteristics, and psychosocial factor, which help in treatment of patients' specific needs. And these are some tools for precision health: the genetic testing, biomarker analysis, wearable devices for monitoring health metrics, and data analysis. So the precision lifestyle medicine in obesity and type 2 diabetes mellitus, it has shown that harnessing individual level biological variant data to optimize diets has already proved valuable for the regulation of blood glucose and may prove of further value for other diabetes-related traits, including weight changes. It can be the next generation for type 2 diabetes prevention. Then we have another latest study published in September 2023, Transformation of Diabetes Care with Precision Medicine. And here, it is shown that integration of omics profiling technologies, big data and machine learning in precision medicine for diabetes has potential to revolutionize the diabetes care. By analyzing the genetic, transcriptomic, proteomic, metabolic, clinician can identify distinct subsets of patients with diabetes and tailor the treatment which are most effective for each individual. Along with this, disease monitoring by various newer technologies like CGM, monitoring lifestyle behavior, dietary, physical, sleep, these various sensors, and blood assays help in precision monitoring, which lays the foundation for precision prevention. Again, this is a same pilot retrospective study on physician-directed genomic-based model for precision lifestyle, almost same. So to summarize my talk, current research in prediabetes has focused on identification and risk assessment, along with intervention strategies and their durability. Newer digital health solutions, the various metabolic markers, community and public health initiative, and personalized or tailored approaches are now available for most of our patients. This field is constantly evolving and new findings are constantly emerging. And these exciting developments have helped us understand and characterize pre-diabetes as well as advances in discovering novel strategies that are not only effective in reducing the risk of its progression to type 2 diabetes, but are also easily translatable to the real world scenario, which holds promise for halting the diabetes epidemic. Thank you.
Thank you, Dr. Verma. A very interesting topic indeed, a very new concept to look for the heterogeneity of the disease and to advise lifestyle modification according to the phenotype of the patient and in an individualized manner. So that is the message which we get carry from your deliberation. So very interesting indeed, and you have covered it in a very interesting way. Just one question from my side. I'm interested to know that actually when we prescribe lifestyle modification to a particular patient, we always flatly say that you have to walk for 150 minutes per week with such and such advices. We don't go for the phenotype and individualize the patients like that. Do you think that different advice should be given to all pre-diabetic or diabetic patients regarding the phenotype, or whom will you advise more resistance exercise and whom will you advise more aerobic exercise? So what is your viewpoint?
Yes, madam. Thank you. I think it's a very practical question indeed, because frankly speaking, till now, we all are just giving a kind of blanket advice to most of our patients, especially about the lifestyle interventions. But yes, I think we should now be more specific in individualizing the tailor-made lifestyle interventions for our patients, because as I've shown, there are different phenotypes. We now take into account not only the hyperglycemia levels, but we should now take into account the insulin resistance part also, and the beta cell function part also, especially if we really want to categorize the patient. And if like somebody has got more of insulin resistance, especially the muscle insulin resistance, so I think in them maybe more strength training exercises would be helpful. So I think these categorization, definitely a slight more understanding, a slight more workup can definitely help us individualizing the lifestyle intervention for better outcomes.
So further work is needed in this aspect. Thank you again. Yes, please continue.
No, madam. Thank you, madam.
Okay, thanks again. So we'll be moving towards our next topic. The new drugs, are they a game changer? And our speaker is Dr. David Chandy. So he is a consultant endocrinologist in Sir H.N. Reliance Foundation Hospital and Research Center. And he has achieved many awards, particularly best paper in various organizations, in various conferences. You can see here that best paper 2015 in Indian Society of Pediatric and Adolescent Endocrinology, and also in Indian Society of Bone and Mineral Research. And the most interesting thing is that he has non-academic interest in long distance swimming and running. So we can assure that Dr. David Chandy will never have pre-diabetes or diabetes, I think. So Dr. Chandy, please enlighten us about the newer drugs.
Thank you so much, madam, for a warm welcome. Thank you, the entire ESI team, for having me over here. So I'll start off with this topic of newer drugs. Are they a game changer for pre-diabetes? So starting off with the background. So we, already had 2-3 beautiful sessions. Dr. Debatya talked about, the role of, the newer literature of, the latest studies that have been done in pre-diabetes. Dr. Abudaya spoke about the lifestyle changes. So continuing on that, on the background of pre-diabetes, what is interesting is pre-diabetes per se has not independently been associated with cardiovascular disease. It's the other parameters of metabolic syndrome, like hypertension, your central obesity, which has actually increased the risk of cardiovascular disease. And again, we have spoken today about the various tests and criteria varying between the ADA versus the IDF versus WHO in diagnosing prediabetes. So there's a lot of heterogeneity in the prevalence of prediabetes. And up to 1/3 of the patients actually revert over time to being normal. That means they go into the normal glycemia range. So what about drugs? Now we have seen that sufficient weight loss by lifestyle changes lowers insulin resistance, but it's challenging and difficult to maintain them in the long run. So here is where drugs have a role. The drugs for dysglycemia basically lower insulin resistance. Like mentioned earlier, some drugs in fact increase insulin secretion like your sulfonylureas and glinides, but there's a high risk of hypoglycemia when you give them in the pre-diabetic patients. So they cannot be used in this group of patients. Now, the most talked about study in this group is the DPP-4 study published in NEJM. We have spoken about it a couple of times today, where lifestyle was actually found to be better than metformin when compared to the control group. You have 58% decrease in development of diabetes in the lifestyle group, while metformin only showed a decrease in almost 30%.
I just want to interrupt. Do you want to share your slide?
The slides are not being seen?
No, it is not visible, please.
Okay, 1 minute.
You share the screen.
Is it seen now?
No, not yet. Yes.
Okay, seen now?
Yeah, the third slide is visible.
Yes. So like we mentioned that, the DPP-4 showed beautiful results with lifestyle, where the development of diabetes came down by almost 60%, while with metformin, the development of diabetes only reduced by 30%. So for drug therapy, what we need to remember is basically lifestyle is much more cheaper. It's generally beneficial. There are no adverse effects, but it's not been shown in any studies to reduce morbidity and mortality. Drug therapy has been advocated by ADA and other professional organizations in two settings. That is in high-risk patients for whom lifestyle interventions fail or it is not sustainable. But if you look at the literature, there are no long-term benefits mentioned of drug therapy, and cost effectiveness, especially with the GLP-1 group of drugs, which are basically patented, it's a big question. For SGLT2, luckily, now it's gone off patent. So what about the data with the older drugs? Like the ADA recommends metformin for high-risk individual patients for prediabetes. Like discussed earlier today, the multi-center randomized clinical trial for Acarbose, the STOP NIDDM trial, showed that the reduction in impaired glucose tolerance was 25% over 3.5 years. But the second part of the trial, which was in Chinese patients published in 2017 Lancet, where they tried to see the benefit in the major cardiovascular events, was not seen. There was no benefit in the reduction in the MACE events. So it does reduce the progression to diabetes, but there's no major cardiovascular event protection. Now, what happens when you discontinue the drugs? So like spoken earlier, rosiglitazone has been studied extensively. Pioglitazone, glargine insulin has been studied. But once the drugs are stopped, if you compared it to the placebo, over a period of few months to few years, the increase in risk of diabetes is exactly the same. So there's no sustained benefit. So what happens when you discontinue the drug? Diabetes develops similarly in both the groups. There is no benefit in insulin resistance or in insulin secretion. So what does the data show of the newer diabetes drugs? So of late, we have spoken a lot about GLP-1 agonists, both for diabetes as well as for obesity. Similarly, you now have the dual agonist Mounjaro. You have SGLT2 inhibitors. So what is the data of them? So compared to the previous group of anti-obesity drugs, it has been seen in literature that your liraglutide, semaglutide, tirzepatide had very good amount of weight loss. Liraglutide in tune of around 6 to 8%, semaglutide up to 15% per year, and tirzepatide an amazing 20%. So with this, definitely you're tackling the issue of visceral obesity. If you get down the visceral obesity, you will have decreased insulin resistance, you will have enhanced insulin secretion, you will have lower risk for developing diabetes. So a 10-year-old back study published in NEJM for liraglutide shows that with liraglutide, you can reduce the risk of developing type 2 diabetes over a 3-year period. So the data is now almost 10 years old. So what does the data that is published with liraglutide recently in the last few months show? When compared to sitagliptin, they found that even within the first 2 weeks of beginning of treatment, it rapidly improved insulin sensitivity. It reduced blood glucose before any significant weight loss. So insulin sensitivity requires GLP receptor activation, and it is this enhanced, level of this exogenous, GLP-1 that promotes this effect. While as endogenous GLP-1, when it was analyzed, when a DPP-4 sitagliptin was used, it did not show similar benefit. So this benefit was much quicker with liraglutide within 2 weeks. So they postulate that this mechanism is independent of the weight benefit. So all of us have seen this slide multiple times, the omnious octet of diabetes. So your GLP-1 and GIP agonist basically tackle multiple axes. It acts at the level of the incretin, it improves the incretins. At the level of glucagon, it reduces glucagon, it improves your insulin secretion. At the level of liver also, there is a beneficial effect. It reduces the hepatic glucose output. There is enough of studies now to show the neurotransmitter benefits of GLP-1 and GIP agonist. So it, among this, 5 out of the 8 axes are covered. Your SGLT2 inhibitor basically works on the kidney. So what about the meta-analysis? In fact, in the last 1 year, there have been 3 meta-analyses that have been published. The first one is a study from China that's been published, where they showed that GLP-1, this meta-analysis of 4 studies of 5 RCTs showed a beneficial effect in terms of regression of prediabetes to normoglycemia in the tune of an odds ratio of 4.5 and a progression to diabetes only with an odds ratio of 0.3. The second, was published 2 months back from Indonesia. It had similar results. And the third was published from Egypt last month. All of them showed similar results. That there's a good benefit in regression to normoglycemia and a good, reduction in the percentage of patients going into diabetes. Now, what about the next group of drugs, SGLT group of drugs? Here, the basic effect is glycosuria. So because of the glycosuria, you have weight loss, but this weight loss actually triggers suppression of insulin secretion. There is an increased glucagon. And what happens is the glucose production level actually goes up a bit. But overall, it improves the glucose sensitivity both at the level of muscle and at beta cells. So again, here in the last few years, there are a lot of multi-analysis done. And here you have data over the 1-year period. The new onset diabetes outcome, especially in patients with pre-diabetes and who had some established chronic disease and heart failure, was analyzed. And you could see there's a 20% reduction in the new onset diabetes group. Now you have 2 studies that are planned currently. One is a study that's been planned in Beijing over a period of the next 12 weeks, where they're looking at HbA1c and oral glucose tolerance test. So a short span with 240 patients are being planned to be analyzed in the next 2 years. Another one study being carried out in Italy currently by Dr. Beccuti's group at the University of Turin is a more longer 1.5-year duration study, where again HbA1c, OGTT, IV glucose tolerance test is going to be studied. We will have the results in the next 1 to 2 years. So we'll have more data about SGLT2 and its benefits specifically in the population of pre-diabetes without CKD and without coronary artery disease. Now, there's some drugs that have come off of late. So there's a drug that's been approved in China, which acts at the glucokinase pathway. You have the doraglatin, which directly binds to the pathway distal to the site of glucokinase, increasing the affinity to glucose, and you have glucose-stimulated insulin secretion. But here, we are worried a little bit of the body weight. But as of now, you don't have any data on pre-diabetes group of patients. You have one more group of drug, which is the hepatoselective glucokinase agonist. Here, they had no risk of hypoglycemia, no detrimental effects on lipids and liver enzymes. But as of yet, we don't have any data on this group of drugs, which have been recently approved for prediabetes. So the take-home message is, like mentioned earlier by both the speakers, lifestyle changes are the best way out, but it's difficult to sustain in the long run. GLP-1 agonist and SGLT2 are options, especially in patients who are obese. But if you have a lean patient who is pre-diabetic, it will be a challenge to start these drugs. Additional benefit is definitely seen in terms of reduction in cardiovascular risk outcomes, chronic kidney disease outcomes. High costs are a limitation when you're talking of patented molecules like GLP-1 agonist. But definitely we need more data, especially from larger trials and a longer duration trial, because we know pre-diabetes to diabetes, the transition occurs over a very long period of time. So thank you.
Thank you, Dr. Chandi. Newer insight into the newer managements of pre-diabetes by the newer drugs like GLP-1 receptor agonists and SGLT2 inhibitors. We are already familiar with the thing that these two groups of drugs are used for cardiorenal benefits. Now, probably in near future, we will also be using these drugs in preventing diabetes and pre-diabetes. And there's one question from my side that you have talked of these two groups of drugs that they cause significant weight loss, and also there are ample evidences that they can revert from pre-diabetes to normal glycemia and also can decrease the incidence of diabetes in case of pre-diabetes. So what about when the drugs are stopped? Because we know that these are all costly drugs. As for example, we know the fact that even in off-label for obesity, these drugs are sometimes used. But when they are stopped, probably the weight gain again occurs. So do you mean to say that these drugs, these costly drugs, and which have various problems in case of pre-diabetes, when they started once, should the pre-diabetic patients continue for lifelong? Or they have to stop somewhere? If they stop it, then what will happen to the patient? Would they again go back to pre-diabetes from normal glycemia?
So what data shows and what is the practical experience that we have had? So we have a lot of patients who are, having obesity who come to us. Like, so I practice in South Mumbai, where a lot of patients, come to us, they take the drug and they're very keen because they heard so much of, the benefits from their friends in US or Europe. And they come with the drug to the OPD and say that we need to start. And most of them, after 3 to 4 months, they land up with some GI side effects. Yeah. And they have to stop. So,
particularly if they don't want to take the injectable drugs, they are more in favor of the oral drugs, and they have GI intolerance also. And so what is your, most of these patients take these drugs for obesity control, not for pre-diabetes, I think. So, but the same thing will happen in pre-diabetes also. So what is your view?
As long as you're giving the drug, you'll have a benefit. Once you stop it, gradually there'll be an accumulation of the visceral fat. Your insulin resistance would go up, and gradually you'll see a change in the HbA1c going back into the pre-diabetic zone and even the diabetic zone. So that's
again and again, we have to motivate the patient for lifestyle modification to maintain it.
So what we usually do is, when I tell the patient is, if you are starting this drug, remember, you need to even go off it. It's an expensive drug with a lot of side effects. So if you're sincere with your diet, sincere with your exercise, we can manage with minimum doses. So your side effects will be less. It will be easier to go off it, long term when you're very disciplined with your diet or exercise. Otherwise, we are starting this at a very young age and you may need to take it for the next 30, 40 years. So if you counsel them well, then we have seen that, with their lifestyle measures and with their diet exercise, we can manage at a lower dose, and at least you can tempt them that, you can even go away, and, if the diet and lifestyle is very good, we can just use this in the initial phase, and later on we can transition completely onto lifestyle and go away from the drugs.
That
so
is
to give an initial push is useful, but to manage it in the long term is expensive.
That will motivate the patient for further lifestyle modification to maintain it.
Yes.
Thank you, Dr. Chandi. So I would invite our next speaker, Dr. Arundhati Dasgupta, for her topic is prediabetes remission. Very interesting topic. Dr. Arundhati is a consultant endocrinologist from Siliguri, Rudraksh Super Specialty Care in Siliguri. She has also an award winner of various conferences and competitive things, and she is the receiver of A.P. Gandhi Award, Diabetes Awareness Initiative Award, and Young Achiever Award. So over to Dr. Arundhati for prediabetes remission.
Thank you, ma'am. So, ma'am, is the slide visible?
Yes.
So good evening, everybody, and thank you, Endocrine Society of India, for making me a part of this wonderful program. I still remember the first program that we had on prediabetes around 3 years back. And it's a pleasure to continue the trend of being a part of prediabetes, the awareness and consciousness of raising it. So I have been assigned with this part, the remission. And it's very interesting, as ma'am just said, because all this while we were talking about halting the progress of pre-diabetes to diabetes. So when we were talking about this, we were basically taking a proactive approach, but we were still not talking about a further proactive approach, a much more proactive approach, in which we were saying that the pre-diabetes part is that we are not going to be complacent about this, because we are going to be very, very active in our management of pre-diabetes as well, so that we can take it back to normal glycemia. So if you talk about remission in pre-diabetes, it's about bringing the fasting blood glucose below 100, 2-RPP below 140, and HbA1c below 5.7. So why are we talking about remission in diabetes? In pre-diabetes? So if this is one of the papers that was recently published, and they kind of reanalyzed the data of the diabetes prevention program. So, and when they reanalyzed the data, they saw that at least the people who had lost 7% of their weight, and they went on to further analyze that what happened to these people. So out of these total who had lost 7% of their weight, which was the target, it was seen that blood sugar levels were normalized in 114 people. That is, they went into pre-diabetes remission, while others, they had lost 7% of their weight, but they had not normalized, they had not gone into normal glycemia. So, and then what was seen that over the years, what happened is that these patients who had achieved pre-diabetes remission plus weight loss of more than 7%, their progress to type 2 diabetes was reduced by 76% compared to the weight loss, only the weight loss category, right? So they said that when you are targeting, you're trying to prevent the progress to type 2 diabetes, it is not just enough to get a weight loss of more than 7%, as has been advocated, but today our attempt should be to bring about the weight loss as well as bring the patient to normal glycemia. And a similar analysis was also done with both the DPP and the PLIS, which has been discussed some time back, and which I will also be discussing. And they similarly said that, anybody who's losing more than 7% of their body weight, along with remission of prediabetes, reduce the relative risk of developing diabetes by 76% within the next 6 years. We had a very interesting discussion about the phenotype. Now, what is the role of the phenotype in predicting prediabetes remission? So this is a study where they basically looked into whether lifestyle intervention had an effect which was different in different phenotypes. So what they did was basically to lower the intake of fat to lower than 30%, saturated fat to 10%, increase the fiber to 15% as a standard protocol, and achieve a weight loss of more than 5%. But if you see here, what happened is that in spite of this lifestyle intervention, 55% of the patients did not revert to normal glycemia. Now, even amongst those patients who had a large amount of body fat loss, even out of that also 40% did not revert to normal glycemia. So in this regard, they said that we have identified a high-risk phenotype, where they said that this high-risk phenotype has a low insulin sensitivity plus non-alcoholic fatty liver disease. And as against a low risk phenotype, which do not have the presence of non-alcoholic fatty liver disease or do not have low insulin sensitivity. So once they assess that, so then they said that now if you are trying to bring about normoglycemia in pre-diabetic patients, it is better to stratify them into the high risk and the low risk phenotype and then bring about your changes, because the requisite amount of lifestyle interventions that will be required will probably be different for both. So this is what they basically showed, that in spite of a similar change in body weight, when you're looking at the low risk phenotype and the high risk phenotype, you can see there, in spite of having a similar weight loss, the changes in the blood glucose, the 2-hour blood glucose, was different in the presence of insulin resistance or in the presence of NFALD. So that is how they kind of categorized that there are 2 types of phenotypes in the pre-diabetes category also. One which consists of low insulin secretion relative to insulin resistance, and this low insulin secretion category was basically associated with a reduced improvement in glucose. So they basically led the way, and they said that, okay, this might help in understanding the pre-diabetes phenotype better, so that probably we can think of more intensive interventions in these individuals with the high-risk phenotype. And then we further on had some very interesting papers coming out about the pathophysiology-based subphenotyping of individuals at the high risk, elevated risk of type 2 diabetes and in the pre-diabetes range. And they kind of clustered these patients in different categories from cluster 1 to cluster 6. And you can see here, cluster 1 is basically with the insulin secretion. There's a low insulin secretion with a high genetic risk. That's like 1, 2. And then you're going on to 3, 4, 5. That's like, it's a high risk category, high liver fat and insulin resistance. They have high diabetes risk, high cardiovascular risk, high nephropathy risk. But then the category 6 is one which has high visceral fat and high renal sinus fat. This category again has a low risk of diabetes. So they said it's important to categorize the pre-diabetes subtypes to understand what is their chance of progressing onto type 2 diabetes. So there have been various, risk analysis settings that have been looked into, and there have been a number of calculators that have been made to predict the progress to type 2 diabetes, and this is just one of them. This is about, you have a tailored treatment because you're looking at these variables and you're categorizing your patients accordingly, which will help you again understand which patient can go into remission and which patient is less likely to go into remission. This is the study which actually kind of first defined about the remission of pre-diabetes first, or not defined, rather, they kind of emphasized the importance of remission in pre-diabetes. And they basically sought to find an answer to 2 questions. Number one, so if somebody is a non-responder in the lifestyle intervention category, can we increase the intensification of the lifestyle intervention, and will that bring better result? And is in those who are at low risk with pre-diabetes, is it effective? Is it worthwhile bringing about the lifestyle intervention? So when they did that, this was a 12-month study, as has been discussed. They were looking into the 2-hour plasma glucose assessed with an OGTT, and they also looked into the liver fat, the insulin sensitivity, secretion, and cardiovascular risk. So the lifestyle was, again, the aims were same, the body weight reduction of 5%, reduction of fat intake of less than 30%, saturated of less than 10%, same as the previous ones. Now, the difference here was the convention intervention group received 8 sessions in 1 year, and that was a 1-to-1 session, and they were advised to perform 3 hours of exercise weekly. Intensive group had 16 sessions, and they were advised to exercise 6 hours every week. And then they had some gradings done. The total score was assessed as to, diet goals, exercise goals, weight goals. And what did they see at the end? So if they divided the results as per the low risk and the high risk, and you can see that this is the control, the conventional in black, and red is intensive. So what is happening in terms of glucose is that you can see that with the intensification of the lifestyle, change, that there's a difference in the curve as you're progressing from 6 to 12 months. Initially, not that much, but eventually there is a gap. If you're looking at insulin sensitivity, low risk category, you can see that there's this broad gap. In the high risk category, there is not much of a gap which is being seen there. Hepatic fat wise, yes, intensive therapy does show a decrease in the hepatic fat, and the cardiovascular risk wise also similar. So what this study said is that in this population at a high risk for diabetes, if you are intensifying the lifestyle changes by increasing the counseling frequency and increasing the hours of physical exercise, that was a superior improvement of the postprandial and a reversal of the pre-diabetes states. So also what was seen that the secondary outcomes were much better. Very interestingly, what was seen is that in the low risk phenotype, even with the conventional lifestyle intervention, there was not much of a change. However, they said that before we extrapolate this to a bigger population, we must admit that the number of patients who were studied in the low risk category were less. So that brings us to the dose effect relationship when you're talking about the pre-diabetes remission. So intensified intervention, benefits on BMI insulin sensitivity were more pronounced. So basically this confirmed that diabetes remission is possible even in the high risk phenotype, but that will need more intensification of the activity. Now, when they analyze this study, what was seen that you divided the non-responders and the responders, and both the groups had weight loss of at least 5%. Then they looked at the liver fat. The liver fat was also reduced equal in both the responder and the non-responder. But what was different was that the visceral fat decreased more significantly in the responder category as compared to the non-responders when it came to remission. And insulin sensitivity also increased significantly more in the responders who went into pre-diabetes remission as compared to the non-responders who stayed on in the pre-diabetes state or progressed to the diabetes. So there they said that pre-diabetes remission, basically you're targeting a point where the beta cells are not yet permanently damaged to a clinically significant extent. So this is a major window of opportunity to preserve the beta cell function in the long term. Also, because we are looking at abdominal fat, which was lost more in the responders. So in future, it is important to identify those factors that promote the loss of this fat depot. Now, if you look at the lifestyle intervention programs, we've had the discussion about the various studies, but we're not talking about type 2 risk reduction. We're talking about reversal of prediabetes here. As you can see, a lot of studies did not actually look into the reversal of prediabetes, but some did, like DPP, where they saw that lifestyle brought about reversal in 40% and metformin in 20%. The STOP NIDDM also had shown 35% reversal of prediabetes. Then we went on to DREAM with rosiglitazone, 50% reduction, ACT now 48% reduction. And then you had the IDPP that showed that in comparison to lifestyle, 32%. Pioglitazone had a 40% reversal of prediabetes. And there were other studies with liraglutide also scale, where also there was a reversal of prediabetes was shown with the use of liraglutide and lifestyle 66% versus 36%. I'm not going to the details of these studies because they have been discussed. But I found this particular review quite interesting. They looked at the scope of recent evidence in terms of nutritional strategies. And they identified 95 articles with around 11,000 participants who were taken into this review. And that was classified into 4 groups. This is across the different countries, as you can see. So this is basically the low calorie group, the low glycemic index groups, the specific food group, and a combination of diet and exercise. And you can see the low calorie and low glycemic index. These are usually the ones, dietary interventions that are advocated for. But here you can see that most of the studies did not actually look at these. They looked at use of grains or plant-based diets or nuts and proteins or dietary supplements. And if you're looking at the low calorie diet, what was done was an energy allowance from 415 to 1700. And then there were others which I went for a very low of 415 to 554 and actually found a better result with a slightly higher calorie of 810 as compared to the very low calorie diet, because it was sustainable and had less tissue loss. And low GI methods also, there were various forms of intervention across the countries. But all in all, what was seen is that mostly studies showed insulin sensitivity and resistance improvement, and improvement in the sensitivity and decrease in the resistance. So if you look at all these 95 studies put together, you can see that the remission of prediabetes was looked at by a very small number. And out of that, also 6 were not supportive of lifestyle intervention. It was only 8 which were supportive. But when you looked at the other parameters, weight or plasma glucose or serum insulin, there were many other studies which were done, and you can see that the results were more in blue, that is supportive as compared to non-supportive. Now, we've also had discussions about the use of medications. If we look at what has happened, apart from the ones that we've discussed, acarbose and pioglitazone and others that we discussed, if we talk about the newer studies, so this is one study that we got, the OASIS-1, and they looked at the subcategory of pre-diabetes patients, and they saw that with oral semaglutide of 50 milligram, 14.4% body weight was lost, and they did go into remission. You can see there fasting plasma glucose decline, 0.38% decline in HbA1c, and with a serum insulin reduction of 33%. But when and then we had another one, the step 1, 3, 4, collectively looking at pre-diabetes and looking at the remission rates, and they did say that okay, there was substantial improvement in those with baseline diabetes in terms of HbA1c, fasting plasma glucose, and HOMA-IR. But when we looked at what happens once you stop it, ma'am was just asking what happens after you stop it. The step 1 trial extension said that there was weight regain, and the cardiometabolic effects in terms of benefit with pre-diabetes also was lost after this molecule was stopped. So after 1 year, 43% met, normoglycemia, 55% went on to develop prediabetes, and 1.7% had type 2 DM based on HbA1c. Tirzepatide, again, once weekly for the treatment of obesity, giving us good results. This you can see with 5, 10, or 15. There was substantial reduction in body weight with remission that was seen in the pre-diabetic population. 95% of patients with pre-diabetes, where it was defined as 2 of the 3 criteria, reverted to normoglycemia versus 62% assigned to placebo. But again, as you go on to see what happens when you stop it, with tirzepatide also we saw similar results, weight regain occurred, and there was also reversal back to pre-diabetes. So current experience with both these drugs suggests that nearly all of the adults with pre-diabetes did have a reversal, 94 to 95%. But in comparison to lifestyle, obviously, which was much lower, but benefits stayed on only while on therapy. Benefits of lifestyle intervention, we must remember, in patients with pre-diabetes who go on to remission may persist for up to even 15 years. We've also had studies looking at the effect of bariatric surgery on pre-diabetes remission, and they did show a very high pre-diabetes remission rate after the bariatric surgery. And as you can see that they had, as they studied across the years, 1st, 2nd, 3rd, and 4th years, the pre-diabetes remission rate was 82, 73, 66, and 58. But it stayed on, it was still 58 at the 4th year of follow-up, and gastric sleeve was associated with higher pre-diabetes remission rate than the Rho and Y, and men had a higher remission rate than females, in the 1st and 3rd year of follow-up. So that is the bit about pre-diabetes remission, and I'll just be winding up with this one final slide. And we know that the tagline now is, please don't be misled by the pre in the pre-diabetes. It's really not the pre. You have to remove the diabetes altogether, not be happy about the fact that you're not progressing on to type 2 diabetes. Many people are there. We see our patients with pre-diabetes, and they've been there for a very long time, and they don't really bother much because they're losing weight, they're following a diet. But we must remember that today, the course of action has to be prevention. Now, why have I mentioned these massacres and rebellions and communes in pre-diabetes? Because these are rebellions and massacres which we don't know about, right? I didn't know about them before I went through this yesterday. These were rebellions or massacres or commune which were nipped in the bud. So when they were in the pre-stage of those rebellions, they were absolutely nipped, so that the world did not, hear about them much. We don't know about them because that did not eventually happen. So it is important. That gives us the message that some things have to be nipped in the bud in the very pre-stage. So the concept today is not about preventing only the progression from pre to diabetes, but to take a very, very proactive approach to attain remission and normoglycemia. Thank you so much.
Thank you, Dr. Arundhati, for your enlightening talk. Definitely, pre-diabetes, the prefix pre should not be meant as a light one. It is not the previous stage of diabetes only, but it is the preventable stage of diabetes only. So let us think that pre is for preventable, not for previous stage of diabetes. So I have beautifully mentioned so many things about the lifestyle modification, the pharmacotherapies, and also the bariatric surgery, different evidence-based approaches. So just one question to you, because time is very short. We have so many lean pre-diabetics in our, you have mentioned about the phenotypes. So in our clinical practice, particularly in what we see in our OPD patients in hospitals, we have seen many, as we have lean diabetics, lean NAFLD, like that, we have so many lean pre-diabetic patients also. And when we advise them to lose at least 5% body weight, it becomes very difficult for them, because they often say that we are not obese, so how can we reduce that 5%? So what is your approach to those patients? Because we, most of the time, we think of lifestyle modifications remembering the obese or overweight patients. So what is your approach? How will you approach them for lifestyle modification?
Ma'am, when we talk about the lean diabetics, we also understand this is also the subgroup where the insulin sensitivity. When we are talking about the insulin secretion and the insulin sensitivity, this would be the subgroup where the insulin secretion would be lower. So actually, these are also patients who are more likely to go on to diabetes, because we just saw in all these studies that at all those subgroups who had a lesser amount of insulin secretion had a faster progression to type 2 diabetes and a poorer remission. So you're very correct. Practically speaking, we really cannot talk about the 5% body weight loss of body weight in them. But what we can definitely do is bring about a healthy lifestyle in them. We can talk about healthy choice of food. We can talk about regular exercise. We can talk, because we've also seen the visceral fat, we've seen the abdominal fat, which is not restricted to the obese alone. They are also very, very significantly there, as you were saying. NAFLD is also significantly seen. So if you're having a subcategory where there is a lean diabetic, lean pre-diabetic, but has NAFLD, but has low insulin secretion, so that would be a category which is going to really progress to type 2 diabetes very early. So the essential steps about the lifestyle intervention will need to be taken. They might not lose the 5% of body weight, or we might not target the 5%.
Whatever they will lose, that will be beneficial.
But at least they
and
will
do you
have
think
to
that pioglitazone is beneficial for those patients? We don't use in our clinical practice, but you have shown data that pioglitazone can reverse and can also halt progress to diabetes in a very good percentage, even more than many
we
drugs.
did see
But we
the
don't,
results
we
with
don't
pioglitazone
use
versus
in our
lifestyle.
clinical
Yes,
practice.
indeed. As of now, no guidelines are talking about the use of pioglitazone, but indeed, maybe if we have any, whatever data we have till now does actually show benefit with the use of pioglitazone. Yes, ma'am.
Thank you so much, Dr. Ranjiti. Coming to the end, almost at the end of today's symposium, so I would call upon the three eminent endocrinologists, the trio, Dr. KVS Harikumar, Dr. Sambit Das, and Dr. Deep Datta, to guide us about the roadmap forward and ESI vision. Are all three there?
Yes, we are there, ma'am. Good evening.
Yes, very good evening, ma'am. We are here.
Good
evening, ma'am. Yes. First, I will start. Good evening, everybody, and thanks to Dr. Shaila and Dr. Sarmishta for conducting so beautifully. I've been listening, excellent talks, excellent inputs, I would say. I mean, so much so that everybody is motivated to prevent the diabetes progression. So that is perfectly fine. That is in line with what is our expectation and what is our intention. Only thing partly I will say is ESI, as it is activity which is continuing, we wanted to keep this as a part and parcel of ESI, number one. Number two, this year, last executive committee meeting, we decided that we will try and bring out a supplement of IJEM, which is dedicated to pre-diabetes, focusing more on different aspects, what has been highlighted by all the speakers. That will help in actually putting it in record, and maybe people who are searching for pre-diabetes
ways and means of prevention, they will have a ready reckoner sort of thing in that supplement. So possibly we would be looking or calling out for others or maybe original articles in that area, whoever has been doing research. So with these comments, I thank all of you for taking part in our program. And I request Dr. Sambit and Dr. Deep for a few words.
Thank you, sir. A very good evening, one and all. And I was also listening to the topics. They were just superb and very eye-opening. So, in contrast to many of the chronic diseases, at least we have some window of opportunity for type 2 diabetes, and we call it as pre-diabetes. I call it an opportunity because, as Arundhati was telling, not only we can at that moment prevent the progression of to diabetes, but we can be more aggressive to bring back to normoglycemia and also control the weight. So in that case, we have two groups to target, and ESI is very committed as an apex body to target both the groups. One is the physician and the other group is the population as a whole, whom we can actually target. So for the physician, as Dr. Harikumar sir has told, I think ESI is planning to come out with a supplement in the next 3 months, and probably that will be released in World Diabetes Day. And that will have some an important guideline, because many of the data are sketchy. So it will actually collect all the data and produce a good guideline for pre-diabetes, and also some original articles, some reviews will also be invited in that supplemented. So that's for the physician. At the same time, we'll continue observing the World Pre-Diabetes Day just 90 days prior to World Diabetes Day, just to tell about the knowledge gained for pre-diabetes and how to prevent the progression of diabetes. At the same time, at the population level also, as an apex body, ESI is committed to do something, and we are planning to do some of the activities for the population in terms of the social media awareness, and also the physical meetings and awareness, just to tell about the entity of pre-diabetes and how one can actually intervene at that time to prevent the progression to diabetes. So these are the things I think ESI is highlighting, and we'll do that.
Thank you, Dr. Sambit. Thank you, Dr. Hari sir. A big thanks to Shaila madam, Dr. Sharmishtadi. Beautiful, very knowledgeable program. And not only this program, multiple state chapters of ESI are doing their own programs in the local languages, targeting not only doctors, but also the general population to increase the awareness. As it has been discussed in the last few hours that yes, this is the time to act, because we can not only prevent diabetes, but also the complications. I'd also just like to highlight the data from CAR study, which was published from AIMS, which looked at population-based data from Chennai, from Karachi and New Delhi, around 4,000 odd population-based data. And they found in a city like Delhi, nearly 40 to 45% of people were living with pre-diabetes. They were not aware of, totally asymptomatic, and another 25% had diabetes. So it is an even bigger grave problem in urban India. And at least when I talk coming from Delhi and talking from Delhi's point of view, pre-diabetes is primarily pre-diabesity. It is almost always with obesity. And as Dr. Arundhati beautifully highlighted in her talk, that it is important to lose weight. It is even more important to lose the central adiposity. So every time our inch size, the belt size goes up, I think that's a big red flag for Indians. Many of us may not put on that much weight, but if our waist size is going up disproportionately, it is a very important risk factor to do something with our diet and lifestyle to prevent diabetes as well as prevent pre-diabetes.
Thank you. Thank you, Dr. Harikumar, Dr. Das, and Dr. Datta. So before going to the open house discussion, just probably there are many questions in the chat box. Dr. Sheila, are there questions in the chat box?
No, ma'am, at present there are no questions. I asked the backend team, they said no.
Okay, so before going to further open house discussion, we have enough, I think 5 minutes time. So if questions come now, I just in 2 minutes want to summarize the things which have been discussed, because many participants may come late. So Dr. P.K. Jabbar has highlighted that ESI is very active in prevention of prediabetes. And he also thinks of the involvement of both government organizations and non-government organizations in this matter. Dr. Sanjay Kalra has told that, correctly emphasized that pre-diabetes has become an epidemic and it has got both urban and rural population in equal percentage, around 15% of it. And he has also told us about the 7 S's for indication of drug therapy. Dr. Sehgal has told about the continuum spectrum of the disease and also the different criteria he has mentioned of different associations and organizations. And he has highlighted the Indian scenario that there are few states which are more prevalent about diabetes and few are more prevalent in pre-diabetes. Dr. Debaditya Das has widely covered all the studies, both for lifestyle modification and for this drugs also, the pharmacotherapy also. And Dr. Abhyuday Verma has highlighted the crosstalk of different organs and also the heterogeneity of the disease so that we can pick up the proper management according to the proper phenotype of the patient, and we can also individualize and personalize and manage the patients in a personalized manner. Dr. Javid Chandi has highlighted that there are, for the newer drugs, the GLP-1 receptor agonists and the SGLT2 inhibitors, they can regress to normoglycemia for any pre-diabetic patients, and also they can halt the progression. So we have to think of these two drugs also in prevention of pre-diabetes in near future. And Dr. Arundhati Dasgupta has highlighted that 76% of decrease can occur in patients with pre-diabetes, the chance of their progress to diabetes. And she also mentioned about 2 phenotypes, and she highlighted that intensification of the lifestyle intervention in these high-risk phenotype that can definitely, even in high-risk individuals also, they can be, the remission can occur. So pre-diabetes remission is our motto nowadays, and we should again emphasize that pre-diabetes does not mean it is only the previous state of diabetes, but it is the preventable state of diabetes, and it can prevent not only diabetes but various macrovascular and microvascular complications. So before wrapping up, I would request Dr. Sheila Sheikh to give the vote of thanks.
Ma'am, before I give the vote of thanks, I had also commented that whichever members wanted to give their suggestions regarding the roadmap forward, they're most welcome. I have Dr. Baswaraj over here and Dr. Mohan over here who wanted to also contribute and make some comments. So if we can take it in the order of alphabets, Baswaraj, you can start, and then I'll ask Mohan to also comment after that.
Thank you, ma'am. Wonderful program indeed. And it was really enlightening, but I think we need to keep on doing these things. One thing which I am personally fond of is about the risk questionnaires. So there are a couple of these diabetes risk questionnaires, be it your ADA risk questionnaires or your very own Indian IDRS. They have their own fallacies. But yes, a diabetes risk questionnaires can actually help us in population-based screening and identify people who are at risk. So ADA comes with a Western cutoff for the waist circumferences, BMIs, and other things. So a typical Indian modification or a Southeast Asian modification for the waist circumference and BMI cutoffs, and there's again a risk questionnaire which we are working, me and Dr. Mahesh DM. We have labeled it as BRS, Bharat Risk Score D for diabetes. So this questionnaire is at very initial nascent forms. The first initial validation is done. So I think incorporating such risk questionnaires would also help us wrap up the journey of the prevention of diabetes or prevention of pre-diabetes in a much more effective and economic way. Thank you.
Very valid point. Thanks for that, Baswaraj. I think we will take cognizance about this in the EC and try to see how we can possibly adapt it to the Indian circumstances. Thanks for that. Mohan, your comments before.
Yeah. Thank you, madam. Nice meeting. Very well arranged. Thank you, Jabbar sir, for taking the long initiative needed. I think the last 3 years, I think we are doing a lot of activities on Pre-Diabetes Day. I think action is required. I think we should all collaborate. I think we should take care of some funds also. Whatever funds or research grants are given, ESI should definitely award whatever required, whatever driven merits or something. We should try. We should stimulate people to do research. Original research are required. I think we should comment on so many new research molecules which have come today.
but I think nothing has been in the pipeline as far as the Indian market. We are not getting desirable result in getting it. So maybe collaborating with the fitness enthusiasts. We have so many of fitness enthusiasts here. Suggestion is that if we can take inputs, we had an ambitious project which we had done initially, but it did not take as a result with it. Shaila ma'am was also part of that fitness, some watch and something we had done an app and all, but it could not go forward. But we should take, I think we should take initiative and do more research on how to get the pre-diabetes among doctors also under check. Thank you, ma'am.
Thanks for that, Mohan. Again, I think we will take more, we will become a little more aware about that and definitely take into consideration what you just told us. In the interest of time, I definitely want to call it a day. I know everybody's been around from almost the last 2 hours. I have the pleasant job of saying thank you to everybody. And at the beginning of it was a fantastic meeting, really enjoyed it. A big thank you to Dr. Jabbar and Dr. Hari for being the most encouraging president and secretary. You just have to request them and they are always agree to whatever concept or whatever idea you have. So big thank you to both of them and the entire EC for agreeing to the concept of having a pre-diabetes meeting. I also want to thank Dr. Sharmista ma'am for the fact that, it was just a phone call away and I could manage to get her to do an excellent moderation. All the speakers at very short notice practically agreed just with one phone call. So big thank you. That's what makes ESI so beautiful, that we managed to sort of break those barriers and have colleagues agreeing to be part of ESI programs at such short notice. I also want to thank my co-secretary, Dr. Saptarshi Bhattacharya, for always being there and always giving whatever scientific input is required. And of course, a big thank you to everybody who came in here, to Deep, to Sambit, to Mohan, to Baswaraj, and of course, all the speakers. Thank you very, very much. And like all good things must come to an end. Good night, everybody. And happy Independence Day. A very, very happy Independence Day to each and every one of us. And meet you all at ESICon 2024. Thank you very much. Thank you.
Thank you, madam.
Thank you, ma'am.
Good night.
Good night.
Good night, sir.
Good night.